All right. Greetings to all and welcome to our webinar this morning, Bridging the Gaps in Maternal Heart Health During Pregnancy, a roundtable discussion on policies and guidelines related to cardiovascular disease in pregnancy. My name is Dr. Michelle Farmer. I am the Chief Medical Officer for Advancing Synergy, and I will be your moderator for this very important webinar. So I want to welcome you all and thank you so much for joining us. The issues of cardiovascular disease in pregnancy is extremely important in that it is the single largest cause of indirect mortality and morbidity among women during pregnancy. And it's very important to note that over 33% of pregnancy-related deaths occur due to cardiovascular disease in women, whether it's pre-existing disease or disease that occurs coincident with the pregnancy. As we all know, pregnancy in women is clearly one of the most important passages and stages in a woman's life. And we need to make sure that we ensure the best outcomes for all women, wherever they live and whatever their circumstances might be. And so we have a great challenge. And as providers and caretakers and healthcare workers, whether you are a physician or a community health worker, or you're involved with health promotion or healthcare research, all of us must come together as one team to promote the health and well-being of women during pregnancy, knowing that this is the best way to ensure a healthy outcome for the babies. So we have a great challenge, and it's with a great pleasure that we will have this opportunity to learn together from our speakers this morning. We have three panelists, and we have an initial presenter who will discuss with us a very important paper related to cardiovascular disease in pregnancy. So without further ado, I will turn the microphone and the responsibility of our first speaker to Uma Vasudevan. And Uma is a researcher and consultant with the George Institute of Global Health in India. And she will give us some background information about the important paper regarding cardiovascular disease in pregnancy. Uma, the floor is yours.
Thank you, Michelle. I'll just share my screen. Okay. Hello, everyone. I am Uma Vasudevan. I am from the George Institute of Global Health. I'm very excited to be here. So in this session, I would like to present the findings of the study which we completed recently, which was undertaken by the George Institute in India on behalf of the Taskforce on Women and NCDs, which was funded by the American Heart Association. So this is a scoping review on the guidelines and policies on cardiovascular diseases in pregnancy, with a special focus on low middle income countries. So in this presentation, we'll be briefly looking at the background of the problem, the research questions that we addressed, the methodology, the key findings of the review, and the conclusion. A brief overview about cardiovascular diseases in pregnancy. So cardiovascular diseases, as you all know, are a group of disorders that affect the heart and blood vessels. So it is a significant public health concern when CVD occur during pregnancy, and which can pose unique challenges. So CVD in pregnancy can happen when a woman who has a pre-existing CVD gets pregnant, or a cardiovascular condition is diagnosed during pregnancy. CVD in pregnancy is a significant cause of maternal morbidity and mortality. They account for over 33% of pregnancy-related maternal deaths, and it is the single largest cause of indirect maternal mortality. It has been cited to be present between 1 to 4% of all pregnancies. So among the pregnant women who had pre-existing heart diseases, 16% had cardiac complications over the course of pregnancy. It's also estimated that the hypertensive disorders of pregnancy, which is the single largest group of CVDs in pregnancy, affect 2 to 8% of pregnancies globally, and a significant cause of maternal mortality in Latin America and Asia and Africa. We also know from literature that cardiovascular diseases disproportionately affect women living in low-income countries and also women of color living across settings. So we already know that women living in certain settings are at disadvantage. Here, the frequency of cardiac disease in women and its distribution is yet to be established. What is only known is that most pregnancies with cardiac disease could be treated if early detection and careful follow-up are part of routine pregnancy care. So given this understanding, we conducted a scoping review to identify and map various guidelines and policies on CVD in pregnancy. This review with the following research questions focused on LMICs. So the questions are: what clinical guidelines exist from WHO, international professional organizations, national professional organizations, and Ministry of Health in low-middle income countries to address the cardiovascular needs of pregnant women? The next question is, where are the gaps concerning the objective of the guidelines in terms of whether it's prevention, screening, or management, in terms of timing, such as interventions aimed across which stage of pregnancy, and the key clinical conditions. So let's have a look at the methods. The review was conducted as per the JBI methodology for scoping reviews based on an a priori protocol. For inclusion in the review, we considered clinical guidelines and policies on CVD in pregnancy. So the documents in English, Spanish, Arabic, and Chinese were included. For translation, we had the help of researchers who were native speakers of these languages, and we also took help of Google Translate. The review was limited to documents published between 2011 and 23 to be reflective of the current medical practice. As for the exclusion criteria, primary research such as clinical trials, cohort studies, case control studies, and conference abstracts with no specific policy recommendations were excluded. And we also excluded conditions such as blood disorders, thrombotic disorders, etc. The information sources, we looked at all the available electronic databases, including PubMed, Scopus, Google Scholar, etc. We also had to look in the individual websites of national and international professional organizations, and also the websites of ministries of health of low-middle income countries. So this is a brief search process. So this is a flowchart straight from the scoping review report, and which shows the complete search and selection process. So we try to look at both government and non-government publications. So the focus was on LMICs. However, we could not find much documents from LMIC, so we had to go for individual website search. So after this process, the search identified some 766 documents with keywords in titles and abstracts. But these were a mix of research studies, reviews, scientific statements, toolkits, textbooks, etc. So after the final screening, 90 clinical guidelines were considered for inclusion, and 17 guidelines were selected based on the inclusion criteria. We could not find any policy on CVD in pregnancy, and therefore we could not include them. So let's look at the findings. 17 clinical guidelines were included in the study. From the selected 17 guidelines, 7 were from WHO, 3 were from International Professional Organizations or IPOs, 3 were from Ministry of Health, and 4 were from National Professional Organizations. So the majority of the guidelines, that is 7 out of 17, were published by WHO, and 3 guidelines were published by IPOs, such as European Cardiology Society, the PGO, ISSHP, etc. Concurrently, the Ministry of Health in Malaysia, Peru, South Africa had published 3 guidelines respectively. And the remaining 4 guidelines were published by national professional organizations in Brazil, China, Pakistan, and Sri Lanka, respectively. So this is a representation of guidelines on CVD in pregnancy included in the review. The guidelines on CVD in pregnancy mainly focus on 2 groups of cardiovascular diseases. One, heart diseases in general, and hypertensive disorders of pregnancy, or HDP. So only 3 organizations, that is ESC, Ministry of Health Malaysia, and NPO of Brazil, had published guidelines for comprehensive CVD care in pregnancy. So these 3 guidelines also had a section on HTP, which also had a section on preeclampsia care in all stages of pregnancy. The remaining 14 guidelines covered hypertensive disorders of pregnancy. These included 8 guidelines which recommended HDP care and 6 guidelines which focused on preeclampsia only. And among these preeclampsia, 4 guidelines provided recommendations for prevention and screening, and 2 guidelines on management. So clinical recommendations, we are presenting it in 2 sections: hypertensive disorders of pregnancy and heart diseases in pregnancy. So let us have a quick look at recommendations for HTP care. Preconception care, or care while planning for pregnancy, was recognized by 8 guidelines, and these recommendations included dietary modifications, calcium and folic acid supplementation, lifestyle adjustments, behavioral changes, and evaluations and risk counseling. We could find certain differences in recommendations. For example, among the dietary recommendations, the NPO of Pakistan recommends a reduction in salt intake, while NPO of Sri Lanka recommends against any form of salt restriction. So when we go to antenatal care, first we are looking at the screening and risk assessment. 9 guidelines recommended screening and risk assessment for HTP, but here also we could find some inconsistencies across the guidelines. For example, the time of assessment and parameters of assessment varied across guidelines. This is a point of contention between guidelines, PLGF and PAPPA test, which is placental growth factor and pregnancy associated plasma protein. These are biomarkers which are used for risk assessment. So 4 guidelines recommended using these tests, while other guidelines such as ISSHP, Ministry of Health South Africa, and NPO of Pakistan recommended against using these tests because of its inconclusive predictive value. So we can see there is a point of contention between guidelines. When we look at the pharmacological management, we can see the pharmacological management addressed either prevention of HTP such as preeclampsia, or management of hypertension such as antihypertensive medications. So when we look at aspirin administration, we can see that there are differences across guidelines in terms of dosage, commencement time, and cessation time. If you look closely, you can see that the aspirin dosage recommended by WHO and Ministry of Health Malaysia is 75 mg, while Ministry of Health South Africa recommend almost more than double of it. So there are differences. Similarly, when we look at the calcium supplementation, here also we can see differences in terms of dosage, in terms of indications, and even 2 guidelines, that is Ministry of Health Malaysia and NPO of Sri Lanka, recommend against calcium administration because of in lack of evidence suggesting calcium supplementation to be beneficial. Now, when we look at the antihypertensive medications, again, there are differences in terms of the targets for BP control, choice of antihypertensive medications, and contraindicated antihypertensives. The target BP control ranges from 130 bar 185 millimeters of mercury till 160 bar 110 millimeters of mercury. So that's a wide variation. Also, one among these three medications are recommended by of sodium nitroprusside in pregnancy, but ESC and NPOs of China and Brazil recommend its use cautiously in extreme situations. Also, use of thiazide diuretics are also a point of difference. When we look at the maternal monitoring parameters, again, here we can see some differences in terms of monitoring intervals and monitoring parameters. When we come to intranatal care, most of the guidelines agree on the need of referral when there is an acute emergency, but only 4 guidelines recommend specific BP thresholds above which referrals need to be made. Also, there is a lack of specific recommendations regarding the signs and symptoms or criteria for referral. When we decide on timing of delivery, again, we can see a wide variation in the recommendations. Starting from 37 weeks till 40 weeks in terms of uncomplicated HTP, and from 26 weeks to 37 weeks in case of complications. Regarding interventions and delivery methods, there is a sort of consensus about going for vaginal delivery and going for expectant management. The recommendations for magnesium sulfate administration to prevent eclampsia also are similar in terms of dosage, route of administration, etc. But only 2 guidelines recommend clinical monitoring to avoid magnesium toxicity. And among the IPOs, like international guidelines, only 1 guideline provide recommendations for low resource setting, especially that is ISSH. Coming to postpartum care, we can see some point of similarity in terms of strict monitoring postpartum in terms of their parameters, but the choice of antihypertensives and the duration of hospital stay, the parameters of monitoring post discharge, like follow-up visits, etc., are different across the guidelines. 2 guidelines give recommendations on community-based follow-up care after HTP. They are Ministry of Health Malaysia and SOGP Pakistan. And in terms of long-term follow-up, only 4 guidelines give a long-term follow-up recommendations, which are limited in this context. Now we can quickly look at the recommendations on the management of heart diseases in pregnancy. Only 3 guidelines provided recommendations for conception care. Recommendations are largely similar, with only difference that Ministry of Health Malaysia recommends starting counseling at puberty, so and at least 6 months before conception. So here we can see there is a sort of life course approach for pregnant CVD care for women. In terms of antenatal care, maternal and fetal risk estimation parameters are almost similar across 3 guidelines, with only difference in terms of exercise testing. While ESC recommends using exercise testing for risk estimation, while others prohibit exercise testing in pregnancy. For thromboprophylaxis, again, heparin, different forms of heparin are recommended by guidelines, but there is difference in terms of choice of medication and also the dosage. Antibiotic use in pregnancy are another point of difference between guidelines. All three guidelines agree on treatment using antibiotics for infectious conditions, but for prophylaxis, only ESC recommends, and other two guidelines, ESC do not recommend antibiotic prophylaxis, while other two guidelines give conditions or indications for antibiotic use. These points like time of delivery, route of delivery, and maternal monitoring parameters are largely similar across these three guidelines. And when we come to the postpartum care and long-term follow-up, the strict monitoring conditions are almost similar in all three guidelines. And they also give protocols for preventing complications, oxytocin and misoprostol usage, etc., and also thromboprophylaxis. But post discharge or follow-up plans in the community, recommendations are limited, and only Ministry of Health Malaysia give a detailed plan of further follow-up of CVD patients, including customized home visits. So summarizing the gaps observed in the guidelines, so we took a health system approach, and we of WHO to recommendation block, we can see that there is a lack of policies on CVD in pregnancy, and we can also see a new focus, a skewed focus on hypertensive diseases, and especially preeclampsia and the other conditions. For example, stroke. We could not find any guideline on addressing stroke in pregnancy. So such conditions are not in focus. So we recommend that we ensure that a comprehensive investment and level governance and leadership. In terms of health workforce, we can see that existing recommendations are not tailored to the levels of health providers or different health providers, and there is undue focus on, not undue, I mean, there is an excess focus on specialist care and very less focus on primary care. So we recommend that there is an appropriate guidance to be made available and accessible to all categories of health professional to take care of patients with pregnant patients with CVD. In terms of essential medicines and service delivery, we already saw that there are so many inconsistencies across the guidelines in terms of recommendations. And also there is a fragmented care continuum. So we recommend a global limited number of clinical guidelines are available for CVD in pregnancy in LMIC and also from global societies. However, between these guidelines, there are important differences in the specific recommendations for care delivery. This calls for a concerted effort by the policymakers, civil society to address the existing guidelines and develop new guidelines and policies wherever found deficient and push for implementation for them to result in fewer and fewer mothers losing their lives to CVD. So this is the team behind this work, Institute India, and this is my supervisor, Preeti Rajvangshi, who's a senior research fellow at CTGI India. And we also have Dr. Jane Hurst, who's a chair in Global Women's Health, the George Institute for Global Health and Imperial College London. So both my supervisors are here, and any questions that you have that I cannot answer, I hope could be directed to Preeti and Jane.
Thank you so much, Uma. This was really very informative. And I think this scoping review, given the high prevalence of cardiovascular disease in pregnancy, has been very helpful. So thank you so much. Um, and I'm so glad that uh, Dr. Preeti is here on the call as well, so that maybe if she wants to offer some of her own perspectives to amplify some of the themes that you've talked about. Preeti, I can be happy to give you a few minutes to add any of your own impressions. Oh, she's not there. Well, then Professor Jane, I would throw those questions.
Great. Thank you. I can see my name's just been changed. I think I was Preeti, but I'm actually Jane Hurst. So well done, Uma. Really lovely presentation. And I think this is a really important initiative to just sort of take stock of what do we know? We know a lot, but there are clearly a lot of gaps. And I think as part of the team doing this, we had started out to think of looking at guidelines and policies. But what most of the audience can see is we presented clinical guidelines because that's all we found. There were no policies in this area. And the second thing was when we focused on the specific cardiac conditions of pregnancy, moving away from hypertension, the field was pretty sparse. And whilst there's, reasonable alignment, because there are only 3 guidelines found, even within them, some quite different areas of clinical practice, which for the cardiologists on the call, I'm sure they would feel fairly strongly one way or the other about these things. But what this illustrates is there's probably an evidence gap too, and lack of investment in research in this area to really determine what are the most effective prophylactic, therapeutic, and monitoring strategies for this very high risk group of women. I'll stop there, but yeah, happy to give more comments.
Yes, no, I think you're right. I think there are clearly some gaps and some needs, considering the high prevalence of this problem and the risks associated with cardiovascular disease in pregnancy. I wondered also if you could say a little bit more in terms of the gaps. I noticed that Uma mentioned the weak emphasis on the needs or the roles and responsibilities depending on the level of the provider. And I'm thinking about that particularly from low resource settings, since we know not every setting will have a specialist in cardiac disease in pregnancy, for example. So would you comment a little bit more on how these guidelines would help out the variety of providers in low resource settings, and a little bit more about the gaps in that regard?
Yeah, sure. I mean, I think, every setting is, of course, unique, and the strengths and the workforce gaps and things are going to vary very much. But, one thing that I guess most of these guidelines, because they were clinical, were fairly generic in whom they were aimed for, but by the language, it would appear they were aimed at doctors in secondary care without mentioning of the healthcare provider. I think what was sort of missing was probably alternate models of care, telemedicine, remote monitoring. Can we use, we all know there's a huge range of monitors and devices and Fitbits and whatnot out there. Could these things actually be useful in people's care when there's access issues? I mean, it's obviously not a replacement for being seen in a specialist center and having the specialist tests, which, let's face it, an echo and these things are probably going to be limited in terms of being able to be done by people who have the specialist skills in interpreting those more complicated tests. But I think a lot could be done beyond there. And I think that's where, I really like Uma's sort of conceptualization around those health system building blocks that, hey, a lot of care in the world for most people happens at the primary care level or even the community level. What role do those cadres play in picking up women early with who are at risk of cardiac disease in pregnancy or complications of, and what of those care package things could be delivered or task shifted down the train. What has to be done in a specialist centre, which there are clearly some things that do, and what could be safely done elsewhere. I mean, I think the general agreement across the board that these women should deliver in a specialist centre with access to both obstetrics and cardiology care, it should remain, and I mean that we can't pretend that those, that there aren't times when that sort of specialist level is needed. But I think that's where hopefully we can find in future iterations of these guidelines ways forward to shift some of the care monitoring at some stages.
Great. Thank you so much. And then the last question I have before we go to our next presenter for you and Uma is, as I hear this description of the scoping review, and I have to say this is a tremendous benefit to those of us who provide care to women in pregnancy and looking also at the perinatal issues, not for both mother and baby, that we recognize that pregnancy, when we're really thinking about the entirety of the period, we think about preconception care. We think about those important trimesters of pregnancy and the antenatal care that goes on, the prenatal care that goes on. But then there's also the postpartum care and the long-term follow-up, because in many cases, especially in pre-existing heart disease, these medical conditions will go on for the lifetime of the mother. And in many cases where there is a heart disease like hypertension in pregnancy, that this woman may go on to have hypertension at a lifelong period. Aside from that, we also know that most women have more than one pregnancy. So I wondered to what extent the guidelines covered all of those periods. Do you see any gaps in the guidelines as it relates to the various phases of pregnancy from preconception to postpartum? Were there any weaknesses in those areas that going forward we would like to see addressed more fully?
Maybe Uma, do you have any thoughts on that first? You're obviously very deep in the data, and then I can comment.
So this was a major gap that we highlighted, that there is a fragmented care continuum, that we could not find a process of continuous care across the stages of pregnancy and in a life course approach. And the three guidelines which were on cardiovascular diseases, to LMIC, yes, there is a consistency of across the stages, but those other 14 guidelines on hypertensive disorders of pregnancy were specific, mostly focusing on one or two stages of pregnancy or the problem at that particular time. So this is a general impression that we got.
And I think just to add to that, fragmentation of care, we know that is a big problem, and particularly between secondary care and primary care, there's often a huge chasm, it would seem, and communication is very poor. But I think what was also, to my mind, a little lacking in some of these guidelines were actually any sort of monitoring, evaluation framework or quality indicators to actually capture where we're doing actually okay and where we're not, and perhaps that's something that as a global group, we could think about what are the basic indicators we'd see. I mean, in my area, I'm an obstetrician by training. I focus a lot on hypertension in pregnancy and diabetes, and there we're just trying to get people to have one follow-up in the community to have their blood pressure checked or their blood glucose checked after birth. And I can tell you it's a big struggle in many areas. That system is not in place, and so you have to build a whole thing around it. And that's not even going to the next pregnancy or lifelong sort of health. So yeah, I think just the way that it's conceptualized, the way we implement it, but also monitor it is important.
Great. Well, thank you very much to both of you, Professor Jain and to Uma, for your great work with the scoping review and from your perspectives on the guidelines and the way forward. This is much appreciated. Just by way of housekeeping in terms of the structure of the webinar, we're going to have presentations from 3 panelists, which will be very important. And I noticed that there are some questions in the chat. I want you to know we're not going to ignore these important questions. We hope that you will stay for the presentations of all the panelists. And then what I will do is go back to the questions in the chat box, and we will have a very lively and interactive discussion after the panelists have had a chance to do their presentations. So please bear with me. We're not going to overlook your questions, and please feel free to put them into the chat box as we go through the panel presentations. Our first speaker is, I think he is with us, Dr. Abhishek Kunwar. He is the National Professional Officer for Non-Communicable Diseases for the World Health Organization in India. And he will speak to us about the importance of the role of World Health Organization in ensuring standardized, appropriate care based on the work of WHO. So, Dr. Kunwar, the floor is yours. Thank you.
Thank you very much, and thank you for giving this opportunity and inviting us in this very important workshop. My colleague, Dr. Amol Wankhede, is also the NPO for the cardiovascular disease. He's also joined. So I request him, if he want, he can share his thoughts also after my presentation.
Sure, Dr. Abhishek. Good evening, everybody.
So again, thank you. And CBD in pregnancy and role of WHO in ensuring a standardized and appropriate care. If we see, just I'm giving some background, and thank you, Uma, for a very wonderful presentation and giving us that. Yeah, the globally the guidelines are very much needed, and for LMICs there need to be some guideline, comprehensive guideline or some framework to to work together on the CVD in the pregnancy, because it's one of the single largest cause of morbidity and mortality in the pregnancy, and challenge still remains. If you see the MMR, it has declined, but hypertension in top 3. So the causes of pregnancy related deaths in India, if you see in India, so MMR is declining. So the maternal mortality ratio is declining, but again, the hypertension is the one of the leading cause for CVDs, and it's not for only for the pregnancy, it's for the overall population also. And personally, I am working for hypertension control initiative program in India along with my colleague Dr. Amol. So we have seen the hypertension has been a real challenge, and unfortunately, while working for the hypertension control, we have not been able to put the pregnancy into that program. So I think this is after listening to you, Uma, and maybe the other the speakers, we will be able to work something in the India with regard to the hypertension and CVD, as we have worked a lot for the hypertension control initiative program in India. So the causes of MMR, if you see that Southeast Asia region, if you see this violet line, 15% the MMR is due to the hypertension. It's a huge. We don't ignore other areas also, like abortion, embolism, hemorrhage. But again, hypertension is the one of the leading cause for the cardiovascular disease in the pregnancy and the deaths. So it is a huge burden as we see now. But having said that, WHO has an evidence-based approach for prevention and management of CVD in pregnancy, but still the work is ongoing. We'll not say that is again, we have seen that there are no concrete guideline for this as of now. There are guidelines, but it's a from different country have a different guideline, but WHO always come up with some comprehensive and guideline and the framework, and I hope that this work is going on. So if we see that the strategies which WHO is going to 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 come up with the evidence generation, and based on the evidence, the guideline development, and again the risk stratification and classification. As you may be aware, there are 3 risks, and according to the classification has been done. and also WHO recommendation on drug treatment for severe hypertension in pregnancy, which is already there. But again, having said that, if all these guidelines come, the training and the capacity building, which is the key area where all each country has to work on, because health systems are different in each and every country, particularly LMIC. It's a challenge, but it's doable. And I can give an example of again the India Hypertension Control Initiative program, which based on the community-based treatment for hypertension and increased the control rate from 16% to 56%. So huge progress. It is doable. Unfortunately, ANC was not part of that, but again, we look forward to have some convergence with the other team in the ministry, and then to bring it together. So, but there are some other challenges are there. But again, the data collection and surveillance, where WHO will be coming with the evidence-based approach on the data collection and surveillance. So, if you see all this can be done based this can be done based on the international partnerships, and of course in the LMIC, and with the LMIC government support from the governments in the each country. So 3/4 of the world's death from CVDs are in LMIC. We cannot ignore this fact, and and India is one of them. So we need to work together. I think that WHO is uh, is working on in this area, and we see that there is a global action plan for non-communicable disease, but for bringing CVD and pregnancy, so resource mobilization will be one of the key area where it has to be brought together. So all the resources has to be brought together. But again, having said that, the policy advocacy with the governments and awareness in the community, awareness at the government and program managers level is the key. So each country there can be a WHO framework, there can be WHO guideline, and there are in most of the areas there are guidelines, and we are also working for NCDs with non-communicable diseases. In each area there are guidelines, but every country we have to come with the practical implementation part. So the implementation is the one of the challenge, and we have heard from previous speakers also about the continuum of care. It all depends upon the starts from the detection of the case and the follow up of the case, and of course service is a key part. So if you see that drugs plays a key role for for hypertension. There in India there is a simple treatment protocol at the community level. Three classes of drugs are there: the calcium channel blocker, ARBs, and the diuretics. So that has been adopted in all the states of the country. So we need to come forward for the CVD and pregnancy. The pharmacological interventions will be different for this. So how to make a simple treatment protocol, how to make the drugs available at the health facility, at the all level of health facility, so that patient comes for the follow up. Sorry, the pregnant women come for the follow up and get the drugs at the health facility and should not go back again, and then the follow up, and then and if there is if the hypertension, which we are talking about, because it's the leading cause. So after pregnancy, to care to follow for the hypertension and follow the patient, and right treatment has been given. So these are there are many things with the health systems we need to see at the all levels, and again the capacity building will be the one of the key area for healthcare providers. So at different level, different healthcare providers are there. So at the community level, there are different level healthcare providers. Second, at the primary level and the secondary level, different healthcare providers. Tertiary level, different healthcare providers. So how to make this? How to all the in partners can come together and have a consensus on to how to build the capacity of the healthcare providers. And of course, research collaboration is always there, because evidence generation is one of the key area, and then the infrastructure support at the health facility level. So actions needed in shaping policies and guidelines for addressing CVD in pregnancy. WHO is working on evidence and providing normative guidance. Technology. So if you see the first, sorry, you see the first, the global and national collaboration, which is very important. So bringing all the global partners and the national governments together, so to build a consensus on this, to how to implement and to reduce the morbidity and mortality for CVD in pregnancy. But technology integration may play a very good, very important role, as in the, if you see the artificial intelligence age now, so the case detection will be maybe a faster. These are, I'm giving some thoughts and examples. So which guidelines, when the WHO may come with some guideline, and with the help of global partners. So the technology integration part maybe play a very crucial role in this today's context. And of course, based on that, guidelines can be tailored at the local level context, and community engagement will play a very critical role, because we have seen all the disease area, all the areas where the health services are to be provided, the community play a critical role. And of course, continuous research and updates with the evidence generation, and based on the evidence, the guidelines are modified, and guidelines can be tailored and accordingly can be implemented. So I hope I will stop here, and if my colleague Dr. Amol has any comment, please you may provide some comment if you have.
Yeah, thank you, Dr. Uma and Dr. Abhishek, for setting the tone on management of NCDs related to heart disease and CVDs in pregnancy. Dr. Abhishek briefly mentioned about India Hypertension Control Initiative. This was an initiative for the management of hypertension, which got an award from UN in September 2022. So why I am mentioning India Hypertension Control Initiative is, in 2018, we were at the same crossroad, what we are looking at pregnancy-related NCDs and disorders. So to begin with, in 2018, for hypertension and diabetes, there were no standard treatment protocol, and NCDs was not a priority. But coming down the lane now, in most of the states in India, we have a standard treatment protocol, and NCD has been now prioritized for management. And what Dr. Abhishek mentioned about those 5 key strategies, we also implemented same strategy in India Hyper Control Initiative, and now they are part of the national program of NCDs based on the evidence, research, and best practices we followed. So definitely in a country like India, where we already have a good a background, a good example of implementation, hypertension control and CVDs in pregnancy can always piggy ride on what we have achieved. So definitely it will be a great advantage for a country like India, which has already set a tone. So we would be looking forward to work with this initiative also. Thank you, Dr. Abhishek, for giving that brief information. Thank you.
Over to you, Michelle. Thank you.
Yes, thank you so much to both of our esteemed speakers, Dr. Kunwar and Dr. Wankide. This was very, very helpful information. And knowing that these are important actions that can be implemented and should be carefully considered, not only by India, but also to empower communities and to build capacities in all low resource settings, regardless of the country. And this is the best way for global change. I really want to thank you because you did enlighten us and set the stage for our consideration of this important issue. And I'm going to again not take the questions at this point, but go to our next speaker. And our next speaker is Professor Dr. Liesl Zulke, and she is she's representing the World Heart Federation. There she is director of Children's Heart Disease Research Unit, but she is also the chair of the Pediatric and Rheumatic Heart Disease Task Forces for the Pan-African Society of Cardiology. Dr. Zulke is served in many distinguished positions, including president of the Pediatric Cardiac Society of South Africa, the president of the South African Heart Association, and she is an active board member of the World Heart Federation and the NCD Alliance. She will present on the role of professional organizations involved with cardiovascular disease in pregnancy. And she is well suited to present on this important topic, having been selected to serve on the Lancet Commission for Women in Cardiovascular Diseases. She is quite familiar with the broad range of guidelines available to the health workforce, and she's going to present the perspective of the national professional organizations. Dr. Zulke, the floor is yours. Thank you.
Great, thank you so much, and thank you very much to the organizers of this very interesting seminar for having me here today, and my congratulations to Uma and her team for that excellent scoping review, which really has enlightened us on looking at the framework that we need to apply guidelines and policies to. So I've taken very much the low and middle income country approach, which I think you can understand. And I want to start with a slide which is representative of the Research Council where I work, because we're grounding everything that we do in the catastrophic and persisting consequences of colonization and apartheid in our country. And that allows us to say, not only do we commit our capacities and resources to ongoing promotion of justice and dignity, but also makes us look at all of policy and guidelines through this particular lens. So we've heard all of these data points, and thank you to the previous speakers also for highlighting some of the aspects of this talk. But what we realize is that the whole landscape has changed. So yes, it is still the leading cause of pregnancy-related mortality in high-income countries, but in high-income countries, it's also a very different dynamic. So we're seeing increasing numbers of women at advanced maternal age, women with comorbid pre-existing conditions such as diabetes, and we mentioned hypertension, and then this growing number of women with congenital heart disease, even quite significant and previously congenital heart disease that was deemed critical and not compatible with adult life, now surviving to childbearing age. But what we've talked about is how the racial, geographic, and ethnic disparities in this pregnancy-related mortality is significant. This is the trends in maternal mortality from 2000 to 2020, where you see the stratification through the various time periods. And the concern is that we haven't made significant strides the way we have in the previous periods. What we were able to say that it has fallen by some degree, by 9.8% in 2020, but the concern is that we are, as a world, still fall short of that target 3.1 to reduce the global maternal mortality to less than 70 maternal deaths per 100,000 by 2030. This means more than 1 million lives will be lost because we have not achieved this target. Now, this is from our own data, from colleagues of mine, looking at cardiovascular pathology contributing to maternal death. So what is very interesting here is a very different scenario because of our low resource setting compared to high-income countries. And 3 of the top causes of mortality, rheumatic heart disease, prosthetic heart valves, and infective endocarditis, are all 3 that manifest completely differently in a low and middle income setting. An example here of valvular heart disease for the cardiologists on the webinar. In the first instance, we see mitral stenosis due to rheumatic heart disease, virtually not seen in high income countries anymore, but a significant cause of maternal morbidity and mortality in our setting. The second is prosthetic heart valves, which again, we deal with very differently in a low and middle income setting. So we heard about some of the guidelines around prosthetic heart valves. In our country, we advocate for mitral valve repair in virtually all young women because we want to avoid the possibility of mitral valve or aortic valve replacement during pregnancy and the issues that go along with that. And the final echo is a child or a young lady with repaired AVSD and residual mitral and tricuspid valve regurgitation, and dealing with that now in pregnancy is also quite different. We mentioned this, I think, Michelle, you mentioned this so eloquently in your questions, that in each of the trimesters, there are different elements at play. And so we have to think of the entire continuum when we think about women during their pregnancy. But what's very interesting for those who are not from the medical fraternity will be that from week to week, this actually varies. So we also need something that's almost more granular than what we sometimes see in more overarching guidelines or policies, because every week changes so dramatically. And then again, as you mentioned, Michelle, one of the big things is that we tend to think that pregnancy ends at delivery. And often this is one of the most vulnerable periods with sudden hemodynamic changes. And in fact, this can go on for as much as 6 months, for example, after rheumatic heart disease or valvular heart disease, during which it's very difficult in a lower middle income setting to follow the patients as they should be. So one of the core principles that we advocate in our societies and our associations is to think around these sort of the continuum of care that we've heard before. So the cardio-obstetric team, the pre-pregnancy counseling with a pre-conceptual health evaluation risk, the monitoring during pregnancy, delivery, as well as postpartum care. But it's often not realized that the most important of that is probably this pre-conceptual counseling. And often, and I think you've brought it out so beautifully in the scoping review, this is not where the emphasis lays. So if we think about some of these counseling essentials, obviously a full medical history. So this is starting right at the very beginning. A detailed cardiac history, because we have now more and more women with pre-existing cardiac disease becoming pregnant. A detailed medication assessment. And this is not only which medications are you on, but are you able to continue these medications? What is your access to care? Are you able to access your follow-up as you need? The medical assessment, clearly, but also in different countries, there are different measurements that need to be done. We heard about exercise testing for patients that have left-sided lesions, such as a bicuspid aortic valve or a possibility of having a dissecting aneurysm. You need to have an MRI. Again, something not readily available in low and middle income countries. These are some of the additional investigations that's often required. And this is an exceptionally important part that I think is probably not mentioned in virtually every guideline, is what is the pregnancy motivation? How strong is the pregnancy motivation? And what are the underlying societal norms that leads to pregnancy? Very difficult when we have patients where pregnancy is contraindicated. So this is the heart team, but often even the heart team focuses on the heart. And we do need to think about things like your overall health, activity, and social review, and understanding of support and resources that are available to this woman at this time. So this is one of the things that we often see in the medical literature, where we see the different risk strategies. I'm not going to go through them in detail, but of course we know about the WHO risk strategy, CARPEG-2, Zahara, ROPAC. And what is often highlighted here are the various conditions that's associated with WH4 categorization where pregnancy is not recommended. And again, some of these that you see, severe mitral stenosis, severe aortic stenosis, is more commonly seen related to conditions such as rheumatic heart disease in low and middle income countries. And this is where we say a follow-up during pregnancy needs to be monthly in an expert center, and delivery also in an expert center, again, not readily available. So you mentioned so nicely, Uma, the 2018 ESC guidelines. And the ESC guidelines for many societies and associations form the bedrock of perhaps associated guidelines or adapted guidelines after that. But if we look at these two papers, the one is the high burden of cardiac disease from a paper from Western Kenya, and then our colleagues from Egypt published this paper. They make it very clear that when we look at these guidelines, comprehensive as they may be, they have significant gaps, some of which you've highlighted already for us, Uma, but they certainly don't have the global perspective as strongly as we need in countries where we work in those areas. So this is taken from the paper where we look at not only mortality, but actually adverse cardiovascular events. So this comes from the paper from Kenya, and you can see that, yes, we've got the risk scores, but in fact, the observed major adverse cardiovascular events were even higher, and that most likely related to the environment in which these women find themselves. I draw your attention to this graphic, which is from a very nice, more recent paper. And what it actually showed, even though in this case they were focusing on Denmark, was what is the long-term outcome for women that experience major adverse cardiovascular events, but also obstetric events. And you can see preterm delivery, small for gestational age, preeclampsia, other hypertensive disorders of pregnancy and gestational diabetes are all in various ways associated with increased risk for ischemic heart disease long term. So when we're dealing with the patient in front of us, we're actually also dealing with her long-term cardiovascular health. And that is also another element that is sometimes missing from our guidelines and should be incorporated into our policies so that we are actually looking after the life course of this woman, not only this particular event that's happening to at the moment, i.e. the pregnancy. And I think this is something that those of us who potentially see a pregnant woman only at one particular interval lack and need to address. So going back to that maternal mortality ratio, you can see, I think many of the people on the call are represented in this heat wave, in this heat map, especially in low and middle income countries. But Africa, you can clearly see as a continent, needs to be a focus of attention in this area going forward. So I'm going to end. I see I'm a little bit ahead of our timing, which is great because it allows for us to have more discussion and more questions. But I'm going to go back to that very first diagram, which was the trends in maternal mortality from, amongst others, the WHO. And what that relate here is a strategic framework for ending preventable maternal mortality. And I just want to focus on this a little bit more because it's so particularly interesting and I think provides important guiding principles. And again, this is not often what we think of when we are heads of societies or we're working as clinicians. So the first is really about empowering women, girls, and communities. And how do we put that into our policies? Protecting and supporting the mother-baby dyad, ensuring that there's country ownership, leadership, and supporting legal, technical, and financial frameworks to support that. And then applying this human rights framework, which you mentioned also, Uma. For me, I think it's really important that we improve our metrics, our quality improvement. I think we heard about that earlier as well, allocating financing and effective healthcare resources. But these are the 5 strategic objectives. So addressing inequalities in access to and quality of sexual, productive, maternal, and newborn healthcare. Ensuring universal health coverage for a comprehensive care for these elements, addressing all the causes of maternal mortality, reproductive and maternal morbidities, and the associated disabilities, not only now, but in the future. And then strengthening health systems to respond to the needs and the priorities of women and girls. And then finally, ensuring accountability, and in my case, also at societies and global institution levels, to make sure we're improving the quality of care and ensuring equity at all times. So in conclusion, we talked about how we take a guideline like the ESC guidelines and then incorporate it into national guidelines. And so the ESC guidelines was adapted and contextualized, and this is part of our national guidelines, which issues from a combined cardio-obstetric clinic that we run. And so it's focused really on different elements. Here I'm just focusing on the WHO 3 and 4 classification, which should lead to urgent referral, this joint cardio-obstetric and anesthetic team, and then, of course, very importantly, this feedback loop back to the main clinic, back to cardiothoracic surgery, and back to postpartum care, so that we can ensure longevity and the best possible outcomes. So for my side, I'm just going to end with the picture of my cardio-obstetric colleagues, and just a delight to work in this clinic, and a delight to have been here today. And I'm going to end there and hand back to you, Michelle.
Thank you so much, Dr. Liesel. You've given us so many things to consider here. And I especially love the fact that you've got that photograph of your team. It really does remind us how important the teamwork is, that no one should be doing this alone. I also love the fact that you brought up those important guiding principles that started with empowering women and girls. Again, I think that as we think about our team, implied in your messages and in your diagrams is that women and girls are a very vital part of this heart team, that we can't do it alone. And even with all of our wonderful degrees and expertise, as you and our other panelists have, we know that the women and girls in these communities are going to be an important key as we look to contextualize very important solutions to these complex problems. So I want to thank you for that. I know I've got a lot of questions, and I think there's some more questions in the chat box. So we will address those things. And I thank you also for giving us these few extra minutes that we will use when we get to the discussion. Okay, so our final panelist is Marcela Del Águila. She is the Director of Health and Wellbeing for ProMujer. She has designed several innovative programs to improve access to care for low resource settings within the Latin American region. And this is a diverse and complex region, so she's well suited to talk with us about the role of community-based organizations in improving access to cardiovascular care for pregnant women. So there's so many other things I can tell you about Marcela. I will add that in that interest of looking at this integrated approach that she will discuss, that she has a master's in health economics and business from Universidad Anáhuac. So Marcela, the floor is yours, and it is an honor to have you as part of our panel. Thank you.
Thank you, Dr. Michelle. Thank you for the invitation. Can you see my presentation now?
Yes.
Thank you so much. Well, first, let me share with you who is ProMujer really briefly. ProMujer is a social enterprise with more than 33, wait, it's not changing here, thank you. It's a social enterprise with more than 33 years of experience working to advance gender equality in Latin America. ProMujer provides tools and services for underserved women so they can reach their full potential, improve their living conditions, and become agents of change in their communities. Throughout our 33-year history in Latin America, we have provided 10 million preventative health services, reaching this number within 5 countries, Nicaragua, Argentina, Mexico, Bolivia, and Guatemala. Provide a good example of how primary care and organizations such as ProMujer play a key role since prevention begins before pregnancy. So I am going to share with you what's the key role of primary care health in contributing to early detection of NCD in women in low and middle income countries. However, there is an additional challenge for disease prevention within these communities. The biggest challenge is access, and the main barriers for providing access are their social determinants of health. This implies going beyond health services in order to address this gap. Educate women around how to play a more equitable role from inside their home and within their communities, give them access to economic resources for starting or expanding their income sources. All this requires developing collaborative networks through alliances with another NGOs, social enterprises, health ministries, and private sector to address their challenges in an holistic manner. So now let's go back to healthcare. Internationally, cardiovascular disease is the leading cause of death in women. With risk factors of CVD continuing to rise, early identification and management of chronic diseases such as hypertension, diabetes is necessary for prevention. According to the article, Cardio-Obstetrics, the next frontier in cardiovascular disease prevention, prevention begins before pregnancy, as preconception screening, counseling, and optimization of chronic disease can improve maternal and fetal outcomes. Let me share with you and the audience some other reasons. Primary health services focus on preventive care, including immunizations, screening, health education, and counseling by identifying health risks, as well as early and promoting healthy behaviors. Primary care helps prevent the onset of diseases and reduces the burden on secondary and tertiary healthcare services. Our healthcare model involves working with physicians, nurses, and community health workers. And by the end of 2023, we reached more than 96,000 patients, offering screening tests, consultations, and counseling. The role of community health workers and their impact has been instrumental in our experience in Bolivia. From January 2022 to December 2023, community health workers have done more than 67,000 screenings. 60% were women, and around 20% have abnormal blood pressure. This number is not so different from the patients that come to our clinics. In more than 44,000 screenings, 50% becomes with abnormal blood pressure. Working with community health workers as key partners to offer health services can be highly effective in improving healthcare access, promoting health outcomes, and addressing community health needs. Another key point is the understanding of the cultural context. That's a quite important thing to do because different cultures have unique health-seeking behaviors. Some may prefer traditional healing methods, while others may prioritize modern medicine. By understanding these behaviors, community health workers, physicians, or another healthcare provider can effectively engage with patients and facilitate access to appropriate healthcare services. Cultural factors influence health literacy levels, which in turn affect individuals' understanding of health information, treatment options, and preventive measures. Tailoring health education materials and interventions to align with cultural norms and preferences enhances health literacy and empowers individuals to make informed decisions about their health. Some of the friendly educational materials that help us offer health information and are well perceived by our patients and are chatbots, posters, infographics, videos, and also we create an audio novella. Our primary health services facilitate early detection and management of health conditions. Primary care providers are often the first point of contact for individuals seeking healthcare, allowing for timely diagnosis, treatment, and coordination of care for acute and chronic illnesses. Also, the primary care providers serve as central coordinators of healthcare services, offering comprehensive and continuous care that addresses the diverse health needs of individuals and families across the lifespan. Our physicians collaborate with specialists, allied health professionals, and community resources to ensure holistic and coordinated care delivery. Another reason is the accessibility and affordability of primary care services, which are typically more accessible and affordable compared to specialized or hospital-based care. In summary, primary health services are essential components of healthcare systems worldwide. Investing in primary care infrastructure, workforce development, and innovative care models is critical for achieving equitable access to healthcare, improving population health outcomes, and build resilient healthcare systems. This is what I want to share with you and the audience, Dr. Michelle, and how ProMujer and other organizations like us has a primary a key role in primary health services. So thank you. I think you're on mute, Dr. Michelle.
You're right. Thank you so much, Marcela. This was a really wonderful presentation, sharing with us, the really important need to embed this complex care into a broader community-based framework. And integrated approaches are really, I think, one of the best ways to go. So now we are going to transition from our presentations to our panelists to ask some questions. I think we'll start, I think maybe Marcela, to build on your comments about the need for a community-based approach. I wondered if you could comment on how the guidelines might help us to integrate a stronger community-based approach and to build the capacities at the community level.
Of course, Dr. Michelle, thank you. Well, to disseminate a guideline related to managing some NCDs, such as cardiovascular disease, the community health workforce requires a multifaceted approach that leverages various communication channels and educational strategies. And some examples that I can share with you could be training programs, develop comprehensive training programs specifically tailored to the community health workforce, including doctors, nurses, and also community health workers. Another example is the integration in continuing education programs. Incorporate those guidelines into existing continuing education programs and allied healthcare professionals by ministries of health, international health organizations such as Pan American Health Organization, and other offer certification courses, continuing medical education, credits, and professional development opportunities that emphasize the importance of early detection, risk stratification, and multidisciplinary management of the disease. And the third example is digital platforms. These digital platforms are online resources to disseminate guidelines, educational content, training modules to the community health workforce, and develop interactive webinars also. That's what.
Yeah. So it's really clear that, the education and capacity building is so important. And this is a question for any of the panelists, really, especially thinking about all of the great work that Uma and Professor Jane did to compile these guidelines, we, of course, our topic today is about bridging the gaps for cardiovascular disease in pregnancy. But I noticed as each of the panelists spoke, there were references to a broad range of health issues facing pregnant women in the context of cardiovascular disease. I think Dr. Liesel, for example, mentioned the issue of ischemic heart disease as a consequence of diabetes in pregnancy. So that, we often think about these categories of complications or challenges in silos, but yet this came up in your presentation. Uma and Professor Jane mentioned the absence of stroke being mentioned. And I immediately thought about women with sickle cell disease and the high prevalence, a high risk of stroke that they would have during pregnancy, knowing that women with diabetes in pregnancy or sickle cell disease may also encounter cardiovascular problems during their pregnancy. So I wondered if any of the panelists might want to talk about where is the best, sort of approach. Do we want to have a siloed approach where we just talk about cardiovascular disease in pregnancy? Or do we think that there's greater benefit to this more broad, integrated approach that allows the guidelines to direct the providers in low and middle income countries to understand that cardiovascular disease may not occur in a specific silo, but in the context of a broader health concern? I open that question up to any of the panelists.
I'll make a reflection just to start before the others jump in. One thing that draws a parallel to me is in the neonatal community, where there was a big thought for a long time that to reduce neonatal mortality, you needed fancy NICUs with very expensive equipment, and it should all be focused at that pointy end. But what we know now is actually to reduce babies dying, you have to focus on the social determinants of health. You have to focus on community-based screening and good antenatal care and making sure. So I think there's a parallel here with cardiac conditions in pregnancy, which are also, for many practitioners, quite scary, because you see them as needing very, very high level specialist care, but actually a lot of the morbidity and mortality would probably be avoided for a large number of women. Of course, there's always going to be a small number who are going to need that expert cardiac obstetric clinic, but the vast majority can probably be quite effectively either prevented or managed, through that more integrated model. So that's just a reflection on that.
Thank you so much, Professor Jane. What about any comments from other panelists?
Can I?
Yes, Dr. Kunwa.
Yeah, thank you. Just actually, WHO promotes the integrated approach of service delivery. But again, having said that, whether it is doable or not. So, for example, I can give some small example of hypertension, diabetes comorbidity. Hypertension, slightly easy to manage, but diabetes, if you see the control, there are different tests to be done. So it may not be easy at the community level. So the issue is that you have to come up with a comprehensive plan with regard to the service delivery also. Once there is integrated approach, one disease is met, but other diseases is not unmet. So how to make possible to with regard to the logistics, with regard to the drugs availability, with regard to the BP apparatus, with regard to the glucometer, there are small things. The healthcare providers. So how to provide services to the same patient or same person who has multiple difficulties, multiple diseases. So service for example, I give you the hypertension control initiative program. We were giving drugs for hypertension for 30 days, but there were no drugs for diabetes. Same patient with comorbid, taking drugs for 30 days, but not taking drugs for diabetes, or taking 7 days diabetes drugs. The patient has to come back again after 7 days. So integrated approach needs to be always has to be come with all the services which has to be there at the health facility. But integrated approach is always a best approach too, because patient come for one service, and patient avails of multiple services at the same time. So we encourage, WHO encourage integrated services, but service has to be there for integrated approach. That is all.
Yeah.
Thank you.
Thank you so much.
Yeah,
Doc-
I certainly concur with both of the previous speakers. I think there are many examples of how an integrated approach could actually accelerate the continuum of care and the comprehensive approach. In terms of South Africa, some of our biggest wins have been around HIV care and HIV rollout, and understanding that that can happen in the community, but it can also happen in an integrated way where you have community health workers about the ARTs, but also check the blood pressure at the same time. My point was that what is quite interesting, and I think we do need to recognize it, is that the antenatal clinic is an amazing opportunity. So we often look at disease processes where I'm talking about rheumatic heart disease now, where we think that there are much more women living with rheumatic heart disease than men. And that's often because of the positive ascertainment of getting them through the clinic again and then keeping them in care. Women stay in care better than men. And so here's that real opportunity to get, speak about a comprehensive set of interventions, to speak about somebody who's pregnant, not only as the pregnancy, but your general health, your general wellness, your general support, so that you can access different levels of service. So one of the things we do need to see is that our antenatal clinics are an opportunity for us, and how can we use that opportunity for comprehensive care? Thanks.
Great. Oh, thank you very much, Dr. Liesel. And I see Dr. Wankedi has raised his hand. If you can unmute yourself, Dr. Wankedi, and make your comments.
Thank you. So as Dr. Abhishek said, so we are dealing with NCDs. So for us, it's a huge canvas involving a lot of elements like pregnancy, their children, those with HIV/AIDS. So each individual or each component have their specific needs. So at the policy level, what we see is there can be integration, but as we go down, management of pregnancy with those CVD requires specialist help. So integration can be achieved to large extent at the policy level, at the advocacy level, health awareness, but going down right at the bottom where we need management for each and individual patient, there has to be segregation because individual expertise is required for management of such issues. So that is my opinion, that at the higher level, there can be integration, but at the lower level, we need specialists, more specialized care. Thank you. Yeah.
Yes, thank you so much. We're going to go back to that topic, I think, which is really important. The issue of, this issue of where the subspecialist is essential. But I did notice earlier in the presentations that there was a question in the chat from Diana Vakamagi, and she asked about this. I think this question would be mostly for our colleagues in India, about civil society in India and how they have developed a very strong support for women's health through their civil society and their sexual and reproductive health programs. I'm thinking a bit about ASHAs, but I think there may be other programs as well. And what could their role be in addressing cardiovascular disease in pregnancy, since they are very much at that primary care basic level? And her second question on that is, how could the Taskforce on Women and NCDs, the sponsor of this webinar, how can this task force help to, sort of build bridges based on these very basic primary care providers?
So Dr. Abhishek would like to answer this.
Yeah, maybe and that's a really great question, suggestion. In fact, I will say there's a great suggestion. If you see that historically, the women's issues beyond SRH is directly largely I can say that I can use that were neglected, including the issues like menopause, maybe postpartum depression, and CVDs in pregnancy, despite of the significant burden, very high burden. And within WHO India, there is a conversation between the NCDs and the SRH team and we have already started looking at the opportunities for the collaboration. And if I can remember correctly, so we had some partnerships during COVID, but now it's a time to scale up and maybe with a strategic approach. But having said that, the task force, with regard to the suggestions from task force, as Dr. Amol mentioned that, so there may be some task force can be suggested on the advocacy for pregnancy related to NCDs, or maybe research and evidence, some task force on the community ownership, maybe multi-sectoral coordination. These are some thoughts. Maybe I'm able to convey the message. I'm not sure if it answers the questions.
No, I think that's a really good point. Organizing, this opportunity to build more of a dialogue around how to build effective, and implement effective programming. I'm thinking I'm going to pick on Dr. Liesel because I know that she has shared with us that she's also a member of the Lancet Commission on women and cardiovascular diseases. And, we think about the Lancet and other similar journals as being very esteemed, highly regarded and respected. I also think about the World Health Organization, Dr. Kumar and Dr. Wankedi, Dr. Amal, great organization. I can tell you that consistently, no matter where I go in the world, and I'm asking about guidelines, the first thing they pick up or the first thing they mention are the guidelines from WHO, World Health Organization. So, we've got leaders who are affiliated, among our esteemed panelists, affiliated with national professional organizations, with large multilateral groups like WHO. How do you see the role of integrating effective clinical guidelines, building policies where we see very few? How do you see the role of these organizations and entities coming together to help us? And I'll start with you, Dr. Liesel, since you do have multiple hats that you wear in this regard.
Yeah, thank you very much for that challenging question. And I think many of us will answer it, from different aspects. I'd like to start by the fact that I am a scientist and an academic, and we start with evidence. And we start with the evidence that we have and critically appraise it. We also realize that there's certain areas where we don't have enough evidence and that we highlight that evidence gap. And once we understand the area a little bit better, Uma's done a wonderful job of highlighting again some of these gaps, some of the areas that we don't have evidence, some of the evidence that we haven't actually moved into policy. We can then actually create momentum around those kinds of things. We've always said we need to measure before we can act. And we've done that in many ways. We've seen some of the data today, but we also have to say, now that we know the measurements, how do we act? Where do we start? How can we make sure we're doing that properly, also in terms of measurement and monitoring and evaluation? So I'm just taking one part of it, but I think that the role of journals like the Lancet and others is to create this evidence base. But what's been very interesting about the Lancet Commission is that they used it to start with the evidence, and then the Commission's role in a way was to move it beyond just the evidence. So a very interesting element, it's come up in the questions as well in the Lancet Commission, was the role of these non-traditional risk factors in terms of cardiovascular disease. So mental health, socioeconomic conditions, the first 1,000 days, how that affects your health, mental health, and your cardiovascular health long term, and the issues of intimate partner violence or coming from fragile health systems and personal social depravity. And so that, I think, is also one of the roles, that we don't just produce the evidence, but we also take it into the next level. So that's just one part of the elephant, and I'm sure my colleagues are going to give you all the other parts.
Yes, evidence to action, which is a very important concept. There are a couple of questions in the chat box, and for the participants who are listening, I want you to know that I'm going to make sure we address all of them. I do want to pick up on one thread, though, that Dr. Liesel brought up, and this is the issue of mental health, the issue of inter-partner violence. It's I guess a sad reality that problems such as cardiovascular disease can sometimes collide with mental health anxieties. I mean, I can imagine that a young woman with rheumatic heart disease having her first pregnancy, she could be 18, she could be a teenager, an adolescent, she may be 21, a young adult, and knowing that she has pre-existing heart disease, this could cause a lot of anxiety for her. So mental health could be an issue that in the context of managing cardiovascular disease, it would be important to consider. Interpartner violence may be. And yet I'm hearing that among the gaps in the clinical guidelines, these gaps may also be there. I don't know if Marcela in Pro Mujer, if you are addressing mental health in the context of pregnancy, maybe, not necessarily, if you can weave in the thread of cardiovascular disease in pregnancy as part of that, or underlying chronic diseases and their role in accelerating mental health concerns. Do you see this as part of Pro Mujer? And where do you find the resources or guidance to address it?
Yes, thank you. Definitely is part of our program. Mental health is a basic component of our health services. Since we don't have the specialized physician in our clinics, we try to do counseling. We, when the women goes to our clinics, we try to see what's happening around her. Not only if she goes because she had a headache or a stomachache, but what's happening in her house, what's happening around her, how is she with her husband or with kids, or what's happening around her. So we see women as in a comprehensive way, that she has a lot of things to do in her life, not only health, mental health, but also she takes care of the whole family. So by asking how are you, how's your house, how's your work, how are your kids, it's a way to introduce ourselves, like in how are you in your whole world. So sometimes that helps women to speak about their life, not only about their health, but actually their mental health. And that's like the first part, to create a trust environment around her, so she can speak more about what's happening in her life. Maybe she's suffering violence based gender or anything else, and that's an important thing for us to do, to listen what's happening in her life in order to create more strategies to help her.
Yes, thank you so much. I just wanted to ask too, particularly among the experts here on this panel, that, mental health is an important issue. Marcela has pointed out that Pro Mujer, feels that they must prioritize some of these assessments. And I think it was Dr. Amal that mentioned, at the end of the day, if you have someone with critical heart disease, you really have to consider the role of that subspecialist. So in the guidelines, so I'm jumping around a little bit, but I'm thinking about Uma and Professor Jane. In the guidelines, we know that if to make a very good state-of-the-art guidelines for cardiovascular disease in pregnancy, we really need to do a thorough job around cardiac disease, cardiovascular disease in pregnancy. But is there room for a reference to say, for mental health guidelines, please see WHO guideline on mental health, to think about, the concern of diabetes in pregnancy, please see the WHO guidelines. So I wondered, Professor Jane, when you looked at the guidelines, did you see these kinds of references so that the guidelines on cardiovascular disease in pregnancy does a thorough job on this topic, but they might mention, please see this guidance or please see that guidance. So that's my question to you. And then from the other panelists, I'd like to know, do you think that's a useful idea? Could we do that? Or is it already being done and I just don't know about it?
I'll just share what we saw in the scoping review. So in terms of reference to another guideline, so initially we had a confusion of how to approach this problem, like which guideline to make it as a reference point and start from there. So it was very confusing initially. So and our focus was on LMIC. So when we started compiling documents, especially from LMIC guidelines, we found that there were multiple mentions about guidelines from high-income countries, like ACOG practice bulletins, and then NICE guidelines from UK, and the ESC guideline. So these were frequently cited in the LMIC guidelines. But then these are specifically focusing on high income settings, and there is not much local contextualization from the LMIC guidelines. So, and because of our inclusion criteria, we did not take the HIC guidelines into consideration. So, but these guidelines were generally referred to frequently. Maybe Professor Jane can add on to it.
Yeah, thanks, Uma. That raises a really good point, and I think one thing those of us in clinical practice are probably frustrated with sometimes is if you're reading one guideline and you're referred to another, and then it conflicts the first guideline. So there needs to be some integration, of the community providing care to this group of people to come together. And I think as things move forward with more digital technologies and AI and things, these things should be far easier for us to cross-link, and they shouldn't be some standalone PDF or paper-based document which doesn't link into anything else. I mean, I think, Michelle, coming back to your point around maternal mental health, this is clearly rising up the agenda internationally, and I think we can all agree, probably neglected or backburnered for far too long in many situations. The resourcing in that is really very low, but I think is improving. And there are some great examples. I mean, I know in India, I was talking yesterday to Vani Sethi from the UNICEF regional office, talking about the integration of maternal mental health and nutrition program, which has been rolled out in 6 states in India. So there are some positive stories, coming through about how we can integrate maternal mental health. As a final reflection, I'll say, my day job, if you like it, is focusing more on diabetes and pregnancy. And when we ask women what their priorities are for research in diabetes and pregnancy, mental health comes right up there. And I'm sure if you ask this cohort of women with cardiac disease and pregnancy, they would say themselves that they're concerned about their anxiety or their mental health or how to support, through the pregnancy, rather than this anticoagulant versus that, which is probably not something that for most women is really going to be top of the list of problems that they're facing.
Thank you so much.
Yeah, I would just like to concur there with Jane. I think that's very appropriate, and I certainly agree. I think one of the things that she's also mentioned is that sometimes it's not anymore the 140-page guidelines with color-coded levels of evidence. I turn to our experience probably as teachers within the university and in the hospitals, and many of our students use things like up-to-date or clinical guidelines, and many of them are cross-referenced in exactly the way you say, Michelle. So you choose a topic, but as you go through the topic, it's got multiple cross references, and it actually reminds our students that there are no silos, that every patient with a particular issue has got all of these other issues as well. So it's also time for us to think very differently about guidelines. And I'm aware that some of the newer guidelines that are coming out are trying to incorporate some of those approaches, some of the graphic illustrations to show the person as a continuum and the issue as being interrelated. And of course, the whole issue with multimorbidity has brought this to the fore. So maybe it's time for us to change our approach as well, so we can reach more people.
Great. Thank you so much. Thank you all for this. There was a question in the chat box that asked, what should we do next? What's our immediate next steps? Is it getting more measurement and data? Is it more capacity building and training? What do you think we should be prioritizing as our next steps as a result of this wonderful scoping review?
That's a big question, Michelle. I think you've stunned us.
I'm only speaking on behalf of our participants who've asked this question. I mean, it is a big question, but we have this significant problem. That over a third of the morbidity and mortality is due to cardiovascular disease in pregnancy. We want this number to go down. We want to see some trends that say we are doing the right things. So what should we do next?
So I'm going to leave it to my colleagues to come up with a medium and long-term scenarios, because those are quite hard to fix this particular problem. But sometimes we can focus on some very small issues. And so I'm thinking about my scenario being within the hospital, etc. And so one of the things is to just be courageous about these conversations. So we note that pediatricians, for example, don't talk about sex. They don't talk about family desire. They don't talk about, some of the issues that we've discussed here, things like intimate partner violence, etc. So raising that at the very earliest opportunity starts that conversation very early. I think the whole aspect of pre-conceptual counseling or the initial conversations allow us to start giving those messages that will allow a safer passage, a better informed passage into and through pregnancy. So from our perspective is that raising that at every clinic visit, regardless of whether there's pregnancy on the cards or not, and starting that the way you would at home with an 8 to 14-year-old, not a 24-year-old who's already going in a certain direction and has already made certain choices. So I remind our young pediatric colleagues that this is the time that you need to start talking about that, and make sure that it's part of every conversation, every consultation, so that you are the person potentially that they turn to when they're having those decisions to make or ideas to start considering. So that was an easy one. I'm going to hand over to Jane.
Okay. And then
Thanks,
we also
Liesl.
have Kunwar after Jane.
Okay, yeah, well, I completely agree with what you're saying, that we need to take every opportunity, but I think we also need to think of, a multi-pronged approach, thinking of improving, the access to knowledge and language used for young girls and women at all different stages and with multiple long-term conditions, so they can access it, in a way they want, where they want. There's so many great, digital solutions and things, and I'm sure a lot of the civil society organizations like Promoher and others are doing great work in this space. And then I guess from the health service provision point of view, we need to take a cold look at ourselves and think, are we offering, that patient-centered care? Are we offering women the care where they want, when they want, and is it accessible? And that will, depending on where we are in the world, it may require a lot of investment or just a bit of tweaking. And then finally, I think for the role of the professional organizations or organizations like the World Heart Federation and the Taskforce on Women and NCDs. I mean, the role there is to bring, us academic experts with you to the table when you're going to speak to ministries of health or you, Abhishek, and WHO to lobby for investment in this area, both in service provision, but in research and monitoring and evaluation as we move forward. And I think, we kind of, there are some clear gaps in the evidence, but we know a lot of what we should do. And I think we just need to push forward, to get that on the agenda. Thanks. I'll hand over to Abhishek.
I think most of the thing has been covered, and yeah, it's not an easy answer, and not a cannot be answered in one webinar. But again, having said that, yeah, we need to start from where, if we start from tomorrow, where we left today. So where we are today with regard to CBD in pregnancy, we need to evaluate that with maybe the LMIC countries start with LMICs, and we need to evaluate that where we are, and then have some sort of goals with regard to short-term, mid-term, long-term goals. What is practically doable? Sometimes we bring everything together in one document, and it may not be implementable. So we need to pick all those things that which are doable actually, which can be implemented. Because at the end of the day, as Dr. Michelle mentioned, ASHA. So ASHA has to start at the India. So what ASHA can do, if we put or give all the documents to ASHA, I don't think ASHA is going to perform. So we need to be very practical that what ASHA can do with the community, because ASHA is not handling only pregnancy. ASHA has multiple diseases to handle. So how we give her options so that she can deliver, ASHA can deliver. Then come to the health and wellness center and the primary healthcare, then secondary healthcare. So I think we need to be very strategic in the policy making and the implementation plan. So that has to be balanced. Policy can be, it's a very nice document, but the implementation strategies with the indicators, and it has to be measurable. When you implement something, it has to be measurable. And documents are very helpful. I can give an example: the HEARTS package of the WHO, and which was not only by WHO, it was the global health partners came together and developed that document. And from this HEARTS package, we took 5 essential components of the HEARTS package: simple treatment protocol for hypertension, drug, how to manage the drugs, procurement till the distribution level, then team-based care, task sharing, patient-centered care, and the information system. These are the small things which can be brought together and built. Because end of the day, we have to look at the pregnant woman. So the service has to go there. So whatever we make, the benefit goes to the pregnant woman. So I think we need to bring all those factors together and make it more simply implementable, so that the outcome is more. So, but it is not an answer, it is just a thought. Over. Thank you.
Well, I think this is a great comment, and I know we have only a few minutes left. I'm hearing that the HEART team needs to include the World Health Organization and other large groups like that, UNICEF. I think it's also saying that professional organizations such as the World Heart Federation, academic institutions and academicians who do the research and collect the data, journals like the Lancet, as well as community-based organizations like Pro Mujer. We are the HEART team. This is the HEART team that I think can help us create the kind of comprehensive programs and guidelines that can be implemented at the community level or at the level of the low and middle income countries. So I think that the Taskforce on Women and NCDs, we have a big responsibility as a task force, but the elements are here. I'm hearing a great deal of interest from the parts of our panelists and the organizations they represent, that the teamwork and the HEART team is comprehensive, multidisciplinary, and has the capacity to address this. So I think this is really great. We do have a few more minutes, and I do want to say my thanks to all of you before we finish. But one question I have relates to some references that some of you have made to technology and innovation. We talk about the electrocardiogram or the echocardiogram and all of these wonderful sonogram that we have many tools. And as innovation becomes more and more possible, these types of devices actually can be utilized at a very basic level. And I'm thinking about the need for data and measurement. Are these technologies and innovations possible at the level of the low and middle income country? And if you, just really any one of you can tell us, is this a dream or is this a reality? I'm going to pick on Dr. Liesel first, and then any others that want to address this.
Yeah, I think it's very definitely a possibility, and it's a reality in certain circumstances. We heard very well from our colleague about community health workers and the role that community health workers play. That's already task shifting and sharing to some degree. The echocardiogram used to be a huge machine that was only in the hands of cardiologists. We now have echoes that can be linked to your smartphone and can be used equally with community health workers or nurse practitioners. So I think we need to embrace the technology. This is a wonderful opportunity for us as these technological advances are really coming every day to make it use for the community that we serve. And I think that those of us or those areas where people are reluctant to share their knowledge, I think we have to actually work with them to make sure that they don't see it as taking over a particular role, but that we're sharing those roles so we can reach many more vulnerable people. So I think it's a very definite possibility.
Okay, great. We've got about 30 seconds. Does anybody else want to make a comment on that, just briefly?
Oh,
yes, Marcella.
Thank you. Yeah, I agree with Dr. Liesel. We work with telemedicine devices with the community health workers, so I think it's a reality now. And I just wanted to add a couple of comments of the last question. I think we need to expand the capacity to inform women more and better from childhood. I think we can't do things alone. We need each other in this by this time. Another thing is to understand the context of the communities and create alliances with other kind of organizations, because as I said, we can do this alone. So just that couple of things to add. Thank you.
I think that's great. I think, we're going to end on that comment with Marcella. We can't do this alone. We are a team. And I think that as Marcella mentions, there are other members of the team that we want to open our doors and open our minds to the possibilities and the potential. I want to thank all of the panelists. I want to thank Uma and Professor Jane for their seminal work to help us to begin to consider this platform. I want to congratulate all of you who work at various levels of organizations, whether it's global organizations like World Health Organization, national and international programs such as the World Heart Federation, professional organizations like FIGO. Really thanks to all of you. And I hope that this conversation can continue in the future. Thanks especially to the Taskforce on Women and NCDs for their vision to find a way to begin to tackle what might be considered a very difficult, almost impossible challenge for women in health, that is cardiovascular disease in pregnancy. We can do this. Help is possible, and improvement in this very serious health challenge is possible. And I thank you all for all that you do now and in the future. And thanks to all our participants who asked very provocative questions. Thank you.
Thank you.
Thanks, Michelle.
Thank you, Michelle.
Thanks.
Everyone.
Thanks, everybody.
Thank you. I'm closing this meeting.